Thank you very much. That was a very nice presentation. Beautiful encapsulation of the highly biased transplant literature. I think it was very eloquently delivered. It is an election year. It is debate season. We've all been seeing a lot of debates. Have you been watching them as closely as I have? You know, they've been contentious. They've been a bit bitter, a bit ugly. I want to commend my opponent for keeping things above board. I'm going to try and do the same things and try and maintain civility within this debate. And to do so, I have some promises for you. Number one is I promise that I will not alienate an entire demographic group. Number two is I promise not to insult my opponent with childish nicknames. And finally, and very importantly today, I promise that I will not bring up my opponent's use of a private email server. But you know how to reach him. All right, so you've seen this data. David just showed it to you. We know that from numerous data sets that 20% of patients with follicular lymphoma will progress early within 2 years, and they have a worse prognosis. I think it's important to recognize when all of these studies were done, whether it's the National Lymphocare study, whether it is the STILL trial, whether it's the Mayo Clinic and Lyon analysis that were performed. These were performed in the stem cell transplant era. They were performed with the availability and the fingertips of autologous and allogeneic stem cell transplant. And in that era, the outcomes are as you see them here. So I think we need to think, what is the next era? What is the new era? How do we change the natural history and the biology of these diseases? And in my opinion, that's going to be with novel agents. So I'm going to start off with the elephant in the room and say, why is an autologous stem cell transplant not the best option for the 60-year-old patient presented in this query who's relapsing within 2 years of R-CHOP? Well, as I've told you, that the overall survival of this patient is poor despite the availability of stem cell transplant, so we need to think further. I'll tell you that not a single prospective study in the modern era supports the use of an autotransplant in relapsed refractory follicular lymphoma. And actually, I think this is a critical point. It's a critical point that if we're applying data, we have to evaluate the merits of that data. And every single analysis that has been shown to support autotransplant has been retrospective studies. And retrospective transplant studies obviously can be highly biased. And the reason for that is retrospective transplant studies focus on who transplanters chose to transplant. And those typically are patients who are younger, fitter, healthier. And so there is a selection bias that makes transplanted patients look like they did better than non-transplanted patients in retrospective analyses. I will further note that in any study and in any retrospective analysis that was presented by Dr. Maloney, not a single one of them actually looked at whether those patients who progressed early after chemoimmunotherapy benefited from autotransplant. In fact, the majority of those patients presented well after the 2-year mark, because that's the time when most patients progress. And so you can't apply retrospective data for a completely different patient population and glean a benefit. In fact, what we know about retrospective studies of autotransplant is that the best predictor of outcome with that transplant is having had a long remission to one's prior therapy. Meaning, if you have chemotherapy resistance, and I would argue that somebody who progresses within 2 years of chemotherapy is chemotherapy resistant, then throwing more chemotherapy at that patient is unlikely to be the primary answer. And I'll also note, as Dr. Maloney confessed, that autotransplant does carry significant risks, including myelodysplasia and secondary leukemia. So we don't have prospective data in follicular lymphoma. Where do we have it? We have it in large cell lymphoma. And in large cell lymphoma, where we widely use autotransplant at the time of first relapse, we know very clearly that if you progress within a year, meaning an early progressor after R-CHOP, having had prior rituximab, your success rate with that autotransplant is extremely poor. So what this tells us is that more high-dose therapy is probably not the answer for a chemo-refractory patient at baseline. He showed you this very nice looking retrospective experience from the DFCI and St. Barts. I would argue that there are actually so few patients at this end of the curve, that it's hard to glean whether that's truly a plateau. But I think the more important curve is shown here on the right, and what this is the incidence of MDS and AML, and here we're approaching 25% with ongoing follow-up with side-TBI conditioning. And so the very late toxicities, including much more difficult to treat entities like myelodysplasia and AML, warrant careful consideration. And it's also important to remember that this data were for patients who were median of over 3 years from diagnosis, meaning they were not those patients who progressed within 2 years in any significant degree. So if that isn't the bee's knees and the cat's pajamas, then what about allogeneic stem cell transplant? And I think there is a stronger rationale to be made for an allogeneic transplant in chemo-resistant patients. So this is a very large, multi-center, retrospective registry database that looked at autos versus allos, again, retrospective data, with over 250 patients in each arm. The median time from diagnosis was greater than 3 years in both arms, was 3 years or greater in both arms, again, not really capturing the early progressive disease patients we're focusing on in this debate. And what you can see are curves that look very similar to the curves that Dr. Maloney showed you as far as progression-free survival. But I think we can't overstate the importance of that bottom curve, which is non-relapse mortality with allogeneic stem cell transplant. And so if we look over here at the risks associated with these procedures, the non-relapse mortality 5 years later, 25% in patients receiving an allotransplant. These are at transplant centers in the modern era. 5-year risk of non-relapse mortality even with an autograft. Acute GVHD, 28%. And I do want to highlight, especially when it comes to these patients on these curves who are doing well, the high risk of extensive chronic graft versus host disease. We need to think not only about length of life, we need to think about quality of life. And those of you who've taken care of many patients with extensive GVHD know it is a significant decrement to one's quality of life. And the chronic GVHD in this analysis was 60%. Which is, I think, really quite high. So how can we actually treat these patients in a biologically directed way without these significant long-term toxicities? And here I'm pleased to report that we actually have prospective clinical trials to help guide our decision-making. So let's first look at what has been proven in resistant disease. So we have a number of trials that have specifically looked at rituximab-resistant or rituximab refractory follicular lymphoma. These are 4 prospective studies that looked at rituximab refractory disease. And what you can see is ibertumumab tioxetan. This is the radioimmunoconjugate available. Response rate of 74%, CR rate of 15%, median duration of response of 9 months. Bendamustine with blinatumumab, data I showed you earlier, response rate of 79%, and a median progression-free survival that hasn't even been reached at 2 years follow-up, showing a really encouraging suggestion of ongoing sustained activity. We talked about rituximab lenalidomide in a different prospective study. This was looked at in rituximab refractory patients, which produced an overall response rate of 62% and a CR rate of 31%. And finally, Idelalisib data I showed you specifically in rituximab and chemo refractory patients with a response rate of 57% and a median duration of remission of greater than 1 year. I will note that the majority of people who progress within 2 years of R-CHOP with follicular lymphoma are actually not rituximab refractory. That's only people who progress within 6 months. The vast majority are progressing within 6 and 24 months in that group. And so some of this has been looked at in that population as well. So if we look at rituximab-sensitive relapsed follicular lymphoma and look again with ibertumumab tioxetan, I think an underused available agent today in follicular lymphoma, response rate of 80%, CR rate of 34%, and a median progression-free survival of 19 months. If you look at rituximab lenalidomide in the randomized trial that I showed you earlier, response rate of 76%, CR rate close to 40%, and a 2-year median progression-free survival. And so what you can see is, particularly in the rituximab sensitive, but even in the rituximab refractory patients, agents currently FDA approved, available at our fingertips today with very encouraging activity. Now, what about those patients who specifically progress within 2 years? Is there any data that any of these novel agents is actually working better or selectively in that group? And the answer is yes. So if we start thinking about targeted therapies, I'll revisit the Idelalisib data. And what you can see here is an abstract presented by one of Dr. Maloney's colleagues at ASH in 2015. And what you can see is this is looking specifically at the patients on the Idelalisib registration trial who had progression of disease within 2 years of their initial therapy. So it's looking at that high-risk group specifically and saying, did this targeted therapy benefit that group, or did it only benefit those patients with sensitive disease? And it turns out it benefited those early progressors equally. You can see here an overall response rate that's equivalent to the overall population, shown here with both CRs and PRs in the majority of patients exhibiting response. If we look at the median progression-free survival, it's 11 months. That's identical virtually to what it was in the overall population. And among those specifically resistant patients who were treated with Idelalisib, their median duration of response was a year. And so this is telling us that if we shift and think about biologically directed therapy, we may actually overcome the liabilities of chemotherapy resistance that have hampered therapies to date. If we then look at the overall survival from their initiation of first-line treatment and Idelalisib, these survival curves are excellent. I would say that these survival curves look as good or better than any survival curve in the transplant literature, and additional follow-up is obviously required. But I think these curves are starting to get at what things might look like in the era of targeted therapy as opposed to the era of transplantation. And when treating a follicular lymphoma patient, it's vital that we think about the long road ahead. We're not thinking about just the next 2 years, the next 3 years, the next 5 years. We're thinking about the next 15 years and so on. And it recognizes that we don't only have the treatments available at our fingertips today. It's those treatments that are coming down the pike, are going to be FDA approved and available to our patients either on clinical trials or in the not too distant future available in the clinic as FDA approved agents. And I think that does inform our decision making for patients today. So what do we have available? Well, there's very exciting data on an antibody drug conjugate called polatuzumab vedotin. This is an anti-CD79B conjugated to monomethyl auristatin E. That's a toxin you know and love from rituximab vedotin fame. You're familiar with the mechanism of action. If we look just at the indolent NHL patients on this study, virtually every one of them had a reduction in their tumor burden using this antibody drug conjugate. 44% of them met criteria for partial response, close to 20% met criteria for CR. And if you can see on these curves, a number of these have Rs under them, and that denotes patients who are refractory to their prior therapy, showing excellent evidence of activity. This drug is moving forward in clinical development. We also have, if we think about intracellular signaling, duvelisib. This is a PI3K gamma and delta inhibitor. This data was presented at the American Society of Hematology meeting just a year ago. And what you can see in this waterfall plot is very exciting activity. This is all nodal reduction in indolent lymphoma patients, the majority of patients experiencing a response, the majority, 62%, 20% complete remission rate. And if you look at the progression-free survival, looking excellent, again reflecting the modern era of availability of targeted therapies. This drug is far along in development as well. What if we target apoptosis with venetoclax? This drug, you know, a BH3 mimetic against BCL2, approved for 17p deleted relapsed CLL. Well, it turns out it's been studied in relapsed refractory NHL, including a large proportion of patients with follicular lymphoma. This is the waterfall plot presented from the phase 1 study to date. Follicular lymphoma patients are in purple, and there are a lot of purple lines on this downward inflection point of the waterfall plot, showing a very high response rate among patients with follicular lymphoma receiving this novel BCL2 antagonist, which is also rapidly moving along in development and already available for another lymphoproliferative disease. And then if we think about that other compartment, the immune microenvironment, we have to talk, of course, about immune checkpoint inhibitors. They are the rage, and there is also promise in follicular lymphoma. These are follicular lymphoma biopsies that were published in the JCO phase 1 study. And what you can see is the red is standing for PAX5, meaning the tumor B cells. The yellow is PD-L1. And what you can see, interestingly, is that the PD-L1 doesn't appear to be staining the tumor cells. In follicular lymphoma, PD-L1 is highly expressed within the microenvironment. So targeting PD-L1 or PD-1 with an immune checkpoint inhibitor might enhance the activity of the anti-tumor response with the tumor microenvironment. There are 2 prospective studies with little data thus far. Idelalisib is a PD-1 inhibitor. It was combined with rituximab in a phase 2 study of relapsed refractory follicular lymphoma. 2/3 of patients responded with a CR rate of 52%, which is a fairly dramatic CR rate for relapsed refractory follicular lymphoma, again, especially with a chemotherapy-free approach. The median progression-free survival longer than 1.5 years. Nivolumab, much smaller experience in the phase 1 study, just 10 subjects, but 4 of them responded, including a CR, and the median progression-free survival not reached at short-term follow-up. This is exciting data, and we'll obviously be paying close attention to it going forward. I mentioned a bit earlier the anti-CD19, anti-CD3 bispecific T-cell engaging antibody, an antibody that has one locus for CD19, the other locus for CD3, bringing them both together, targeting, harnessing the T cell with the B cell to induce activity. And among 37 patients included on the phase 1 study, the response rate was a remarkable 80%, with a CR rate of 40%. The follicular lymphoma patients on the swimmer's plot are marked with red stars, and you can see a number of remissions. Numerous of them are ongoing at time of last reporting. And the last immunotherapy I'll comment on is anti-CD19 CAR T cells. These are looking very exciting, and you've heard about them repeatedly at this meeting already. This is data from the University of Pennsylvania that was presented a year ago at ASH. Small number of patients, but in this small number of patients, the response rate was very high, more than half of patients achieving a complete remission, and the duration of response looking very excellent with at a median follow-up of just over 1 year, so still need more time for follow-up. I do want to give a shout out to my distinguished debate adversary for publishing data also on anti-CD19 CAR T-cell therapy in follicular lymphoma. Just 6 patients presented in the phase 1 study, but 80% responded and 40% in a CR. Most of these CRs are ongoing at the time of last follow-up. So I think CAR T cells are looking extremely exciting in follicular lymphoma, and advanced studies are ongoing in large cell and are getting up and running in low-grade lymphoma, and will most certainly add to our treatment armamentarium in the not-too-distant future. So I'll conclude now by saying that novel agents are preferred over transplant in this specific 60-year-old patient with early POD after R-CHOP. High-dose chemotherapy for chemo-resistant follicular lymphoma is throwing good money after bad, in my opinion, and there's no prospective data to support it. Allogeneic transplant does benefit some patients, no question about it, in highly selected retrospective analyses, but of course carries significant risks, non-relapse mortality and impaired quality of life due to chronic GVHD, which we'd love to bypass if we could target these tumors in a more biologically directed way. And thankfully, those novel biologically directed therapies are proving effective in prospective studies with numerous agents now available and many others not too far off in ongoing clinical trials with encouraging early results. Thanks very much.